I want your thoughts on statins in general.
Yeah.
And I want to know, because you already know this, I'm not telling you something you don't already know. They're very polarizing.
100%.
I'll be honest with you, I don't love it, at all myself. And I do know that it has its benefits, but also one of the things that I know that I want you to talk about too, besides your opinion, is that I know that it can actually increase your calcium score. It can increase your LP little a, and it has side effects. So what are your thoughts on it? Because you know how a lot of people have their thoughts one way or another on it, just like how things are nowadays.
Sure.
Just break down for me your thoughts and what you think is fact and what you think is farce.
Got it. So one thing to be said about statins is they very clearly show cardiovascular risk reduction. Very clearly. That's the first statement to be made. Just to give you an example about this, there was this trial called the Wascops trial. They did in the west of Scotland. They followed men for 5 years. They gave them a statin. There was benefit shown in the trial. They then went back and looked at that cohort of men 20 years later. So we had a 25-year chunk of data looking at, what happened to those men, both negative, both positive. Even if you took statins for just the 5 years in the trial and never for the 20 years thereafter, there was still benefit being shown compared to the people that never took it. And there were no long-term signals of harm. People worry about things like dementia and worry about things like cancers and liver problems. And, we didn't see anything like that. And there was benefit. And there's numerous examples of this, right? So primary prevention trials, secondary prevention trials. But I think the other thing to say quite clearly is statins are overused. And that's because they have been boiled down to be used for high cholesterol and not to treat plaque. And that's where I have a big problem with the use of statins, is we are over-medicating people for abnormal numbers, not disease process. And so we are clearly over-treating a big chunk of people. What we're also doing about statins, when I say we, I mean the medical community, is we're ignoring people when they have problems, or we're not actively surveilling people for problems. This is what responsible medication use looks like, is you recommend something, you talk about the risks and benefits, you be honest about risks and benefits, because nothing comes risk-free essentially, and then if someone has a problem, you take them away, or you respond to that, reduce it, take them off it, whatever it might be. So, unfortunately, as a sort of a lipidologist, I see a lot of people that have had tons of troubles on statins. So there's no question that some people get chewed up by statins and don't tolerate them at all. Well, guess what? We shouldn't have those people on statins. That's crazy. We're hurting some people with statins. But there are a large number of people that do just fine. And so you don't want to throw out the baby with the bathwater and say statins are universally bad or universally good. You want to pick the right people to treat with them, and you want to make sure that you're not hurting that particular person with your intervention. And if that's true, then keep going, right? Now, the statins are also not all the same. So you have fat-soluble statins, you have water-soluble statins, you have different breakdown pathways, all this kind of thing. And so, some people will also do very poorly on some kinds of statins and do just fine on others. Having aches and pains on statins is, myalgias are certainly the most common side effects. I unfortunately see a lot of people, particularly older people, who kind of have aches and pains, and everyone's like, shut up, you're old. And you take them off their statin, and they're like, man, I feel 20 years younger, because no one's bothered to sort of listen to them and say, geez, maybe this is from the statin. So I use statins a lot. I have a very low threshold to giving people trials off of statins, just to check, if whatever's bothering them is from the statin. And at the end of the day, there's nothing too magical about statins compared to the other cholesterol-lowering meds. The final common pathway of all our cholesterol-lowering meds thus far are upregulation of the LDL receptor that clears cholesterol. So when you take a statin, you lower cholesterol in the liver, it makes more receptors. When you take a ezetimibe, you absorb less cholesterol, your liver makes more receptors. When you use PCSK9 inhibitors, you're stopping the protein that breaks down the receptors. So that's the final common pathway. So what that means is there are some small unique benefits to statins, like a bit of an anti-inflammatory effect, etc. But at the end of the day, per unit lowering of cholesterol, all of these things are interchangeable. And we have such good and varied options in this day and age that I'm kind of a pragmatist. If someone rides at me hot and heavy about statins, I'm like, I'm never taking statins. I'm like, all right, we'll try something else. Like it's not a big deal. In my mind, it would be reasonable to try them. But if that is the breaking point for this person between lowering their risk or not, fine, let's move on. We've got other things. We don't have to be tied to statins, right? So, we are lucky in this day and age that we have options. And that's sort of my approach to them.
Sure.
The other things, neurocognitive, there's a lot of details to the neurocognitive stuff. Some people are impacted by statins with executive function stuff, be it concentration, be it sleep, what have you. It isn't, with the data that we currently have, it isn't any permanent or long-lasting damage to the brain or the memory. It certainly isn't risk for dementia. So the analogy I like to give is sometimes swallowing statins for some people is like swallowing a Benadryl for other people. While the drug is in your system, you feel kind of fuzzy and out of it, not like yourself. And as the drug gets out your system, you feel back to normal. But of course, if you get that, then hey, don't use that statin or move on to something else. Increased risk of diabetes is present with statins, but you're not powerless to that. Meaning, if you are taking drugs and doing nothing about your diet and your exercise, those people are more prone to go into type diabetes anyway. And those people teetering on the brink of diabetes with their lifestyle choices and genetics are more likely to be higher risk to be recommended statins. So the data gets a little bit skewed as to why there's a slightly higher incidence of diabetes on statins. But if you work on your diet simultaneously, which you should be doing, and pay attention to sugars, carbohydrates, you can largely completely avoid that risk. And so this is why a lot of these things are complex and nuanced, right?
Yeah, that's good information. I really, really appreciate that. Thank you for the insight. Yeah. It's nice to get an honest insight.
Yeah. But okay. As I said, I'm respectful of the fact that doctors misuse a lot of meds, statins included, and I'm not surprised that some people get completely annoyed and thrown and lose their ability to lower their risk because they're like, geez, I've been mistreated for 10 years. Why would I listen to any of these jackasses, right? I mean, to be honest.